Radiation again.
Again?
Yeah. Well, it seems like only just a couple of weeks ago we talked about radiation again.
Seems fitting for this cold, wintry Melbourne day. How many people have I just offended?
Yeah.
What I meant to say was
Don't
we've got
hang
some
up.
amazing guests to cheer
Don't
us up
dial off straight away. But
on
yes,
a cold, wintry Melbourne day.
you have your fumbling surgeons here trying to introduce a podcast completely devoted to high-tech radiation technology and
Yes.
fantastic recent trial data. So that's what we want to talk about today. We want to talk about stereotactic radiotherapy for prostate cancer.
Absolutely.
Particularly localized prostate cancer. That's going to be our theme today, which is very exciting. There's a lot of talk about this and it's a huge advance. Can we give high meaningful doses of radiation into the prostate with very small number of fractions, very attractive to patients if we can show it's safe and it works well.
Absolutely.
So we want to focus on that to start with our fantastic guest in studio, which we're excited about.
High impact paper, and it's always thrilling to have a great guest who's first author of a Lancet Oncology publication.
And we're going to get
right
to that.
next to me.
And we also have a fantastic guest on the line who we'll get to as well in a couple of minutes' time. But yeah, and Shankar SIva, a friend of the podcast on our advisory board, is back with us as ever. Shankar, welcome back to GUcast.
Hello, hello. Wouldn't miss it for the world.
Fantastic. And we're joined in studio by Dr Alison Tree, clinical oncologist from the Royal Marsden and the Institute of Cancer Research in London. And you've been on the podcast before, right at the start of GUcast 2 years ago, Alison, on Zoom. But here you are in person.
I know. I'm so delighted to be here. I'm very impressed by the setup. It looks amazing.
Terrific. Well, look,
It's so wonderful to have you here because last time was online and we've been through a whole pandemic since then.
Yeah.
So
I know.
welcome.
We were just saying that, weren't we? We were talking about the pandemic just kicking off last time, and here we are 2.5 years later, and still feels like it's lingering, but hopefully on the up now.
Well,
absolutely.
Finally.
You know what I did? I did go back and have a listen to that podcast that we did. It was in April 2020, right at the start of the pandemic. And we talked about stereotactic radiation. Actually, things have moved a lot since then. And we had Pete Ost on the line as well. And during the podcast, you were saying, I hope we'd be coming down later in the year. You're going to come down to this meeting that you're here for this time.
That's right. Only 2 years late.
Here we are, 2 years later. But great to see you and
Thank
welcome. But yeah, Shankar, so do you want to tell us why Alison is here and why it took 2 years to get her down eventually?
Yeah, absolutely. We're very excited to have Alison here, actually. So we're holding our Peter Mac Sabre Symposium. We haven't been able to do that since for the last 3 years. And we have some exciting guests, but, a headline act is Alison, who's coming down to give us some interesting talks about prostate SBRT as well. So it'll be very exciting.
Wonderful.
Yeah, terrific. So I was just saying it, Renew, the building seems to be crawling full of eminent radiation oncologists from around the world have popped into Peter Mac because your conference is on around the corner, kicking off with workshops today, I think. And
Correct. Yeah, we had to unfortunately hold it off-site today simply because of, some pesky virus that's in there around.
Yeah, and big numbers.
That's still lingering.
Sadly.
Terrific. So that's going to be what we're going to kick off with, the theme. But also we've got a fantastic guest on the line. And we were just talking about the same thing. Our Zoom guest dialing in from Toronto was one of our last visiting professors physically in the building, I think, Renew. And it's a great pleasure to welcome Dr Gerard Morton, radiation oncologist, professor of radiation oncology at Sunnybrook in Toronto. Gerard, thank you for joining us on GUcast.
It's so nice to join you. Thank you very much for the invitation. It's great to zoom into a little bit of sunshine. We're just having our first snow day in Toronto today. I look out my window here. Everything is blanketed in snow. Looks miserable. Renew, I know you talked about snow being
the
nice,
sunlight you can see here are the studio lights, Gerard.
It's not so much fun when you have to shovel it.
It's true.
Yeah, so Gerard's a radiation oncologist with a lot of expertise in brachytherapy, really. I'm sure all aspects of GU oncology, but brachytherapy. And so it's very interesting, isn't it, to talk about SBRT because it's very, brachytherapy is the obvious other comparator here, delivering super high conformal doses with HDR into the prostate. So we want to roll that into the conversation as well. But yeah, Gerard was here just at the start. I think it was actually after we closed the gates to China in March 2020.
Wow, yeah.
And I recall him being here at the MDT and doing a great talk. And there's a photograph of us out on the landing downstairs here. And that was literally in my folder of visiting professors, the last visiting professor until just recently. So nice to see you again, Gerard. Do come back. Don't be frightened off.
Please.
I think he pulled the gate closed as he left Melbourne and we didn't open for 2 years after that. So.
All right.
Yeah, but Shankar, do you want to introduce what we want to talk to Alison about, in particular this very important paper she published in Lancet Oncology just a couple of months ago?
Yeah, absolutely. I think a lot of us are quite well aware of this very high impact publication, the PACE-B study, and I I'd like Alison maybe to ask, just give us a 30,000-foot view of the actual study and perhaps some of the findings from the Lancet Oncology paper.
Yeah, thank you. So the idea of the study came from about 2011, so that just gives you an idea of how long it takes to bring these kind of projects to fruition. But it came as a conversation starting actually with Accuray, the manufacturer of the CyberKnife machine. And we started having a conversation about what it would take to make this kind of treatment standard of care. And as oncologists, we like a randomised trial. We're a big fan of those at the Marsden. And we felt that to actually move the needle, we needed proper randomised evidence, large-scale clinical trial comparing 5-fraction SBRT with whatever would have been that man's standard of care, be that prostatectomy or longer course radiotherapy. And so we started PACE with the intention to recruit 874 men to each of those arms. And what we've just published is the 2-year toxicity outcomes of PACE-B. And PACE-B was the part of the trial that randomised men between 5 treatments of SBRT and then standard treatment, which changed over the course of the study, actually. So when we started, it was 78 gray and 39 fractions. So that means 8 weeks of daily radiotherapy for the man. That's quite an arduous thing to go through. But when the CHIP trial showed us that 4 weeks was just as good as 8, we switched to make PACE randomising between 4 weeks and 5 days.
And what were the high-level findings that you saw in the paper?
Yeah, so the paper we've just published this year was the 2-year toxicity data. And overall, what we saw was that the toxicity was low in both groups. So actually, GU and GI toxicity is pretty low with modern radiotherapy techniques. Comparatively, between the two arms, the GI toxicity was a little bit better for 5 fractions, and the GU toxicity was a little bit worse. So it's a bit like a seesaw. You lose some, you gain some. Mm-hmm. But overall, the toxicity was very low and very encouraging with these very high doses per fraction given over 1 or 2 weeks, so a very short schedule.
Do you think that 2-year readout is the right time point, or do you need to wait a bit longer as well?
Yeah, so if you look at the longer term data we have from other trials, like the CHIP trial, most of the long-term toxicity occurs in the first 2 years. The toxicity curves are pretty flat after that. So I think we've seen the measure of it. Obviously, there are some events after that, but differentially not likely to be different between the two arms.
Interesting. And I think you've also mentioned that based on the back of some of that work and other work, you're even considering reducing the number of fractions from 5.
Yeah, so we've been on a journey, haven't we? We've gone from 8 weeks down to 4 weeks. We've shown those equivalent. We've now gone from 4 weeks down to 5 days. We don't yet have the 5-year efficacy outcomes of that 5-day treatment. But the obvious question is, how much can you push it? The best story would be if we could say we'll go down to a single fraction of radiotherapy. We'll see the man, we'll tell him he's got prostate cancer and cure him on the same day. That was the fairy tale I was shooting for. But this is where Gerard comes in, because actually he's shown some very important data. He's done the hard bit for me and suggested that that might not be the best way forward.
Jared, what are your thoughts?
Yeah, no, I mean, I think there's a few things. Obviously, we had the same goal. We have the same goal that hopefully we could get a patient to come in, have one treatment, go home cured of his cancer with minimal toxicity. That certainly was our goal. We looked at doing this using HDR brachytherapy. Certainly, we found that a single fraction of HDR as monotherapy was really well tolerated. So, you know, we achieved half of this, but unfortunately, the efficacy was poor, and we found we were having, you know, a 30% recurrence rate within the prostate at 5 years with a single fraction. And this is very different from what we were seeing when we give 2 fractions. And this is part of a randomized trial where the recurrence rate at 5 years was only 3%. So there was a 10-fold difference. So despite what we had hoped to see, and despite what our, you know, simplistic view of radiobiology may have predicted, when we actually put it to the test and looked, we found that, you know, single fraction needs to be looked on with we've got to be very careful when we go to a single fraction. And, you know, it really begs the question, well, how low do we need to go? Certainly 2 fractions is pretty good. And I think if we can get away with 2 fractions, either of HDR monotherapy or of SBRT, that it will be a huge achievement.
Wow. 2 fractions.
Yeah.
And I was interested because I think in the UK, for certainly up to intermediate risk disease, almost everyone's doing chip style hypofractionation. Is the old days of 6 or 7 weeks of external beam gone?
They are for us. So in the UK, I doubt anyone's giving more than 4 weeks. Certainly that's what the NHS is encouraging now, and the data would support that. Why make the man come any more appointments than he needs to? That doesn't make any sense.
It certainly changes the experience for the patient, doesn't it?
Sure, yeah.
What do we do here, Shankar?
So it depends. So in the intermediate risk is definitely the 4-week hypofractionated approach from Prophet and Chip. For high risk disease, we tend to use a longer course and elective nodal radiotherapy as well. So yeah, I think we could argue that whether we need to do that much, but it's certainly we're still a little bit behind the UK in terms of adventurousness in that point.
Alison, in the paper, you had included both intermediate and low risk patients. What was the proportion of each, and what was the pathology for all these low risk patients?
Yeah, so the trial was essentially an intermediate risk trial. It was over 90% were intermediate risk. We very rarely treat low risk prostate cancer unless we can very much avoid it in the UK. So there's only a small number of low risk patients, probably more early on in the trial when people were still shifting their practice. But yeah, I would not recommend treating low risk prostate cancer.
Yeah.
And Gerard, can I ask you perhaps, you do have some experience with treating both the lymph nodes and the primary with stereotactic radiotherapy. Do you want to talk a little bit about that?
Yeah. So we've been doing a lot of trials, both with SBRT alone and SBRT combined with brachytherapy. I think we're fortunate. You know, we have many really good new treatments available to patients. So in this, you know, as we move forward, it's really the patient who's going to be the winner. We have many ways of combining, you know, different fractionations, different treatment modalities. I think our you know, we went from, as you said, using like brachytherapy as a boost with something conventional, which would be given over 5 weeks, to brachytherapy combined with 5-fraction external beam. And that's something that we are doing at the moment as part of a randomized trial, where we're randomizing patients to brachytherapy plus either 5 fractions or 23 fractions of external beam. And my guess is that 5 fractions are going to work out just as good as 23 fractions, both in terms of side effects and in terms of efficacy. When it comes to SBRT alone, again, we've got quite a bit of experience. Drew Loblaw, my friend and colleague here, has really spearheaded this, and he has completed a well-known Saturn clinical trial. This is a phase 2 study where patients were treated with a 5-fraction protocol, delivering 25 fractions to the pelvic lymph nodes, as well as concurrently given 40 gray to the prostate itself. Again, seemed to be very well tolerated and effective. And he's even gone one step further by also delivering a boost to the dominant lesion within the prostate. So when it comes to where we're at with external beam or SBRT alone for treating high-risk patients, our current spot would be to deliver 5 fractions, 25 gray to the lymph nodes, 40 gray to the whole prostate, and possibly even a 50 gray boost to the dominant disease within the gland.
Mm. Wow. So is that our current standard of care then? Let's talk about intermediate risk cancer. It's some sort of at least hypofractionated, but preferably SBRT approach or brachytherapy. Is the cancer control good enough? And what about the slightly increased GU toxicity we saw with the slightly longer follow-up, I suppose? Yeah,
no, that's a fair point. So in the UK, obviously we're a little constrained. We can do some things quickly and other things slowly. So until we get the 5-year biochemical outcomes from PACE-B, I don't think there'll be wholesale change of the way we treat every man in that category. But since COVID, because of pressures on services, a lot of people have been treating in 5 fractions, and I think that's quite justifiable. We've got other clinical trials out there showing that 7 fractions is as good as 8 weeks, so I think the chances of there being a big difference in biochemical outcomes is really small. But I think we'll wait for a sort of national pronouncement until we've got PACE-B, which will only be next year. So.
Maybe I can ask a question also to Gerard, just to press him a bit. A man comes to your clinic, how do you counsel him as to which treatment to pick, brachytherapy or SBRT?
So I think we're really fortunate. We've got a whole range of treatments to choose from. Obviously, it depends on the risk group of the patient, whether we're going to be treating with monotherapy or a combination of treatment. And that really has to do with the risk groups. So patients with higher risk disease, our current standard of care would be to use brachytherapy boosts. And this is, in accordance to current guidelines. Now, having said that, not everybody is likely to need a brachytherapy boost. Not everybody is going to need this degree of such a high dose to be delivered. Certainly, if someone is older, if they've got comorbidities, if their life expectancy is going to be a little less, then we wouldn't normally pursue brachytherapy, and we tend to treat these patients with external beam only. When it comes to monotherapy, again, there's usually a discussion with the patient. Our current standard treatment for younger men with intermediate risk prostate cancer would be brachytherapy. And currently we use low dose rate brachytherapy. We have an ongoing randomized trial comparing HDR in 2 fractions to LDR monotherapy for these patients. For patients that are maybe a bit older, I guess our feeling is that probably they don't need quite as high a dose, quite as high an ablative dose as we're delivering with brachytherapy. Perhaps we can permit a somewhat higher integral dose to the rest of the pelvis, which is what happens with external beam. And being supraconformal using brachytherapy may not be as necessary for these older patients. So when I see a patient, if the patient is younger, now what's younger? It used to be anyone who was younger than me, but that actual population is getting bigger and bigger as time goes by. I'm not sure why. Maybe men are just being diagnosed younger. I'm not quite sure. But generally for younger men, we tend to prefer brachytherapy compared to external beam. My bias is to try to avoid giving external beam radiation to younger men just because of concern about the long-term toxicity, including second malignancy. But for older men, maybe we don't have that same concern, and I'm much happier to treat these patients with SBRT or some form of external beam.
Seems to me that being able to offer any sort of very hypofractionated approach really changes the value offering for people, because it can be quite a deterrent, especially here in Australia. Patients may take quite a while to get to a regional centre, and they getting away from the farm for up to 6 or 7 weeks, et cetera, et cetera. So that's why it's really impressive to hear this move towards hypofractionation. I think the data is clearly showing it. But what about the higher risk patients? So I think we've established that this is a high standard of care in intermediate risk patients, but what about higher risk patients?
Yeah, so I mean, we don't have any radiobiological data to suggest that the high risk, high Gleason grades perform any differently in terms of their reaction to high dose perfraction versus low, but we don't have a lot of data, to base that on. So once again, we're running another clinical trial. This is called PACE Nodes, the latest PACE baby to be born, and it's following in the footsteps of the Sunnybrook team, really, so taking their idea of treating the whole nodes in 5 fractions and putting that into a randomized trial. So we're randomizing men between prostate only and prostate and pelvis on the basis that we still don't know which men need pelvic irradiation. But if anyone does, then surely we should be able to do it in 5 fractions. And that trial has just started. It will be just under 600 men recruited over the next couple of years. So we'll at least have some prospective safety data, and we'll have some comparative efficacy data to answer that question.
That's really interesting. My learned urologist colleagues are always impressed by fancy technology. What about the MR-Linac? Where does that fit in the whole piece?
So Gerard was talking about his data looking at 2-fraction HDR brachytherapy, which has been fantastically useful, and he's been giving me lots of advice about how to do it. But we wanted to test this on an external beam radiotherapy machine to avoid the invasiveness and the clever technology and clever doctors you need to deliver HDR. And so we've been doing it on our MR-Linac, so we have an Elector Unity. And the reason I picked that was because when you've just got 2 shots to get the dose in the right place, I want to make sure I can see what I'm doing. And for prostate, that means MRI. And I want to adapt where the dose goes on a daily basis. There's really no point making a radiotherapy plan 3 weeks before and then delivering it on that day when the anatomy will be different. And that's one of the beauties of HDR. They don't have to do that. They can treat the anatomy they see. And that's what MR-guided radiotherapy now brings us. So we're using that machine as a tool to test out 2-fraction external beam radiotherapy in a trial called Hermes. And this is a small, at the moment, single centre, 46-patient trial. Half of the patients get 2-fraction SBRT and half get 5-fraction SBRT on the assumption that will be standard of care by the time we report.
That's on the same machine for the 5-fraction?
Yep, so exactly the same. So when the machine's the same, both arms, it's just the dose that we're changing.
Because I think you're probably aware there's a new paper coming out very soon from Dr. Amar Kishan called Mirage,
Yeah.
which is testing MR-Linac versus conventional. What are your thoughts on that?
Yeah, so that's caused a lot of a storm on Twitter, hasn't it? Repeatedly, where people, I think, getting confused about the trial. And what MR set out to test was CT-guided radiotherapy with 4mm margins versus MR-guided radiation with 2mm margins. There are two different parameters that are changed, and that's the question that keeps coming up on Twitter, and we have to keep reiterating there are two things that have changed. And what he surprisingly to me showed, I didn't think that he had a shot at showing reduction in toxicity with a 2mm difference in margins, but he showed a halving of the toxicity, both bladder and bowel toxicity, with the MR-guided small margins. And that's not even adapting the radiotherapy field each day, it was just delivering it based on the MR image, so not even using MR-guided adaptive radiotherapy to its full capacity yet. So yeah, surprising result. I mean, encouraging for those of us looking at MR-Linac radiotherapy, because it's at least a signal that we can achieve something meaningful for the patient.
So when we introduce expensive gadgets, as Shankar said, in surgery we do, and we very rarely can produce high-level evidence to show that introducing this particular surgical gadget improves the outcomes. It's just so many challenges with surgical trials, equipoise, etc. Surgeons just not doing good trials. But as radiation technology evolves, it's a question to all of you. Are you measuring stuff like that to such a degree you can say MRI based radiotherapy for prostate cancer is going to be better than IMRT versus conventional radiotherapy versus protons versus this? How do you sort out, because you have a lot of technology for delivering good doses, and does it evolve a little bit like surgery? My sense is it does a bit. There's a kind of a bit of a common sense, right? Look, prostate's much better seen on MR. We see the rectum much better. Of course it's going to be better. Us surgeons would like very quickly decide that that's just a better way to do it. And I know it's a more expensive gadget, but is it a challenge in producing the high quality evidence as your technologies evolve, Alison?
It's a massive challenge, and I think we're kind of aided now by the fact we have more than one manufacturer. Obviously, Da Vinci cornered the market in robot-assisted prostatectomy. What's their incentive then to do R&D? Whereas with radiotherapy, if you've got multiple different companies producing different devices, I think we should be pushing them as a community to actually put their dollars on the table and say, you run the clinical trials to show that our machine is worth it. Because we're all in constrained healthcare environments, aren't we? These machines are expensive. How do we prove that investment for the healthcare institution is worth it? And how do we prove that it makes a difference to patients, more importantly?
And Gerard, if we get down to 2 millimeters, is this as conformal as you'd like with brachytherapy, or it's still different for kettle of fish?
So I think the big difference between brachytherapy and any form of external beam, of course, is the integral dose. I mean, unfortunately, we're still not able to get by the basic laws of physics. And so when we're doing brachytherapy, the radiation is coming right from within the prostate itself. We get very rapid dose fall off. So the dose to surrounding organs is just essentially much less than that, which we get with MR, protons, any other form of external beam radiation delivery. So while the high dose is as conformal with MR guidance or IMRT or VMAT, as we get with brachytherapy, we're still going to be splaying dose to a larger volume of normal tissue with any form of external beam, which is why for the younger patients in particular, I do have some concerns about that. This is something we're not going to easily show in a clinical trial, but it would be one concern I have, and one reason why I think brachytherapy still has a lot to contribute in this area.
I'm not doing a very good job, am I? I'm convening a SABR symposium, and Gerard's still mounting a very compelling case for brachytherapy.
Yeah.
Can I ask a question about the delivery of these radiations? Is it a bit easier to deliver SBRT, to take on SBRT, if you're deciding, right, we're going to move from traditional fractionation to SBRT or HDR brachytherapy? Is it easier to develop an SBRT program than it is to do a HDR brachy program? Well, I'll ask you guys first and ask Jerry.
I think Jerry's probably has the I guess both at his fingertips, probably, which is a good person to ask. For us, I think clearly there's a lot of infrastructure that's required with theatre time and other stuff for brachytherapy. That's a real overhead for delivering that type of treatment. From an SBRT perspective or SABR perspective, they're very similar. A lot of the technologies and the techniques are similar. It needs a little bit of nuance to be able to deliver that particular type of treatment, but the gap, I feel, is smaller. I don't know what you think.
Yeah, I mean, treating with SBRT is easy, if you inverted commas, in the sense that it's very similar to what we normally do, what we've all been trained to do in 20 or 39 fractions. And people like Gerard are actually quite rare now in the world, so that people that can deliver good quality brachytherapy. I don't do any brachytherapy at all, and I guess most centres don't have an expert brachytherapist. So the technology, the resources are much easier to deliver external beam radiotherapy across a wide variety of healthcare environments.
That's my sense as well, and I know we obviously do both in here as well, running a big HDR program and a big SBRT program, but this is a big cancer centre, so I suppose in a common cancer like prostate, that's the question, Gerard, is SBRT, despite your fabulous program, more of a democratization of delivering these very conformal hypofractionated doses? Will more people be able to do it, or should we actually be trying harder to develop HDR brachy programs all over the place?
Yeah, it's a good question, Declan. I mean, what's hard, what's difficult, is taking out someone's appendix hard or easy. I mean, I couldn't do it, but for most surgeons, it's bread and butter. It's very easy. So certainly for brachytherapy, any form of brachytherapy, a different set of skills are necessary, and this is something that's certainly very achievable. But I completely agree with Alison and Shankar, their comments that the number of people who are doing brachytherapy has been decreasing everywhere. And this is something that there are many plans to address, because it is important to, continue training people. Now, I think we're fortunate, certainly in Canada, that we do have pretty robust training programs in place, but this is certainly not everywhere. And I completely agree that it's much easier to do SBRT. SBRT is essentially the same as what we've been doing forever with external beam. There are some, subtle differences, but conceptually, every radiation oncologist is able to deliver SBRT, whereas not every radiation oncologist is able to do brachytherapy.
Yeah, and it's a bit like surgical techniques, isn't it? It doesn't really matter. The single most important thing is the skill and the experience of the people delivering that treatment to you, not whether it's robotic surgery or open surgery. These things that I don't think we should get too blindsided by this, that, or the other. Because I must say, I'm very encouraged to hear of these developments, because it certainly makes it more attractive for our patients, I think, to be able to say, well, look, this technology is now very advanced. You're going to get delivered very good doses into your prostate, but in a much shorter interval, either by this technique or that technique. And we now have this very impressive data on toxicity as well. So I'm very encouraged.
Yeah, it is definitely encouraging. I was recently in Adelaide, and they're building the first proton therapy centre there in Adelaide. And I was at a meeting, and I asked a radiation oncologist, what's the role of proton therapy for prostate cancer in the future? And he said, well, SABR is just so good that he doesn't see a potential role. What are your thoughts?
Yeah, I wouldn't disagree with that, actually. I don't think there's any data that suggests that protons have an advantage for prostate. None that I've seen anyway. Yeah, full stop.
Exactly.
I think you have to be careful. You might have some radiation oncologists throwing some things at the podcast machine if you... But I agree with Alison.
I don't think there are many
There's
advocates of protons. It'll only be a few people throwing their coffee mugs at them.
Yeah.
That's okay, we're protected.
Yeah.
I think so. Yeah, look, that's fantastic. Well, thank you.
Very good, thank you.
Thank you very much, Gerard. Thank you for joining us from Toronto. It'd be lovely to see you back down again. And we've lots of collaborations with your surgical colleagues there, as well as I know the radiation oncology units across these three centres, Sunnybrook, the Marsden and Peter Mac, have lots of collaborations. So yeah, it's great to hear from you.
My pleasure. Thank you for the invitation. It was great.
Nice to see you.
Yeah, and Shankar and Alison, good luck with your SABR conference. This is an annual shindig now, isn't it, covering all aspects?
Let's hope it's back to annual.
Let's hope it is, exactly. And is GU a good part of it? Is it only prostate, or are we talking other stuff?
GU tends to be a big part of it. I'm not sure if that's me or not, but yeah.
That's great.
There are other cancer types available.
Thank you very much. Super. All right.
Well, you've already seen the penguins, you've been to the beach in the rain, and there's not much more to do.
Well, Oh, it's been a beautiful visit. I've enjoyed myself despite it raining.
Fantastic. Well, thank you very much, folks. A radiation episode. I hope all of our multidisciplinary listeners enjoyed that. We love learning from our radiation colleagues, and it's great to hear of all that progress, isn't it, Renee?
Yeah, it's been fantastic.
Fantastic. Well, we'll be back again soon. Do send us your thoughts on future topics, and give us a like or a subscribe or a review of all those things that seem to matter. Take care. Goodbye.